For those of you who don't know, SHAAP, Scottish Health Action on Alcohol Problems, we're a partnership of the Royal Medical Colleges in Scotland and the Faculty of Public Health. And our aim is to contribute to debate and provide the authoritative voice on alcohol problems. I am actually delighted to be able to host today's event because today's report is actually a really significant step forward. Research began in 2019 in recognition of what we knew was a positive contribution that was being made by the specialist addiction nurses in deep end practices in Glasgow. And we wanted to explore that further. For those of you who don't know, the deep end practices serve the 100 most deprived, socio-economic deprived communities in Scotland. With this project looks specifically at some deep end practices located in Glasgow. So today's research is very important, firstly because, as we all know, there's not really enough research or evaluations carried out of different models and alcohol services. So this is going to be a significant contribution to that knowledge. But secondly, as we probably all know, alcohol harms disproportionately impact people in our poorest communities. If you live in one of our poorest communities, you're 7 times more likely to be admitted to hospital because of alcohol, and you're 4 times more likely to die because of alcohol, compared to counterparts in the wealthiest communities in Scotland. So any work to address this inequality really must be highlighted. So I'm really keen that we all learn from this and, where possible, adapt and adopt it wherever we can and wherever is appropriate. So I'm going to hand over to the research team who will talk us through their findings. So as they're speaking, please do ask any questions in the chat, and where possible, we'll come to these questions in the Q&A at the end of the session. First of all, Dr Andrea Mohan will be speaking. So Andrea is a lecturer in the School of Health Sciences at the University of Dundee. She's got a track record of public health research, and she's also Vice President of ICARA, which is the International Confederation of Alcohol, Tobacco and Other Drug Research Associations. So she brings a depth of knowledge to this, and other members of her team are Dr Clare Sharp and Dr Danielle Mitchell from Stirling University. After they've spoken, then we'll be moving to Linda Doonan, who works in the PCANOS service in Glasgow, and then Dr Andrea Williamson, one of the GPs involved in this project. So please can I hand over now to Dr Andrea Mohan.
Okay, thanks very much, Eleanor, and thanks everyone for wanting to come today and listen to our study findings. It's a really interesting study, and very glad to have led the research. And as Eleanor mentioned, it is a significant, it's a significant project, and hopefully we'll have some positive steps forward from that. I'm sorry, that's just the university's fire alarm going off, but it's just a scheduled one. So I'll just pause for a second. Sorry about that. I forgot that it's Wednesdays at 11. So today we're focusing on the findings of our project, and we focus specifically on the Primary Care Alcohol Nurse Outreach Service, or PCANOS for short. And I just want to acknowledge, first of all, SHAAP for funding the study, to Andrea Williamson and the Deep End Steering Group for all of their support in terms of setting the initial setup of the study. To the PCANOS team themselves, without them, we wouldn't have been able to recruit our GP practices and our patient participants. And also to Michaela Jones from the Scottish Recovery Consortium, who sat alongside with Andrea on our study steering group. And I'd also like to acknowledge Emily Begley, who was a researcher in the early stages of this study. So I'll just pass on to Claire now, who will take us through the context for the study. Thank you. Next slide.
Thanks, Andy. So just before we start talking about the study itself, it's useful just to go through some background. As many of you will already be aware, and as Eleanor mentioned, alcohol causes significant harms to health, and there is a wealth of evidence linking it to various health conditions. In Scotland, alcohol deaths are high. 1,190 people died from a cause wholly attributable to alcohol. And again, as mentioned by Eleanor, alcohol harms are not evenly spread throughout the population. Those in the most deprived areas experience higher levels of alcohol harm. It's also worth mentioning the impact of COVID on drinking. There's some evidence to say that people already at risk of alcohol harms have increased their drinking during COVID, and this might serve to widen any existing inequalities. Next slide, please. Okay, so there's a wide range of different individuals and organisations involved in helping people with alcohol problems. One of the traditional models is that primary care has a focus on screening for alcohol problems, offering brief interventions or advice, referring patients thought to require more support to specialist alcohol services. However, within that model, we know that there are some barriers, which mean that not everyone with alcohol problems, that not all of those patients' needs can be met within that system. For example, research has highlighted various barriers in primary care, including a lack of GP time, skills and resources, and also challenges in identifying and engaging patients. Within specialist services and organisations, there have been issues relating to budget cuts, structural issues which have seen a combined service for alcohol and drugs, and problems with engaging patients, for example, due to the stigma associated with accessing these services. So there's a recognition that primary care could play a useful role in addressing the needs of people with alcohol problems. The potential of primary care is that they see a large percentage of the population. They have the potential to build relationships with patients. Next slide, please. Okay, so this study is about a model which combines specialist alcohol skills with the primary care setting. And Eleanor mentioned the attached alcohol nurse pilot, which was piloted, an initiative that was piloted in 2015. And this involved two addiction nurses working quite closely with a selected number of GP practices. And those practices were part of the deep end practices, which are those which are in the most deprived communities in Scotland. And this study showed that addiction nurses and GPs could work well together in these practices. And one of the recommendations that came out of that was that a longer study, a longer initiative be conducted. And one which also sought feedback from patients about the service. So in 2019, the primary care alcohol nurse outreach service was implemented. And this study is a study of perspectives and experiences with PCONOS, as well as wider alcohol services in the community. Okay, I'm just going to pass back to Andy now.
Thanks, Claire. Next slide. So the aim of our study was to explore the experiences, perceptions of managing alcohol problems within deep end practices. And in terms of sampling, we approached 10 deep end practices who had 4 of them who had initially signed up to the attached alcohol nurse pilot, and 6 who had signed up to PCONOS. And from these practices, then we were interested in recruiting practice staff, including GPs, nurses, practice managers, but also link workers who, although aren't directly employed by the practices, work in the practices. The addiction nurses, or we call them the alcohol nurses here, as well as service users or patients. And so we conducted interviews with 25 participants in total. 18 of them were professionals and 7 of them were patients. Next slide. So we can just see the breakdown here of who participated in our study. So in total, we recruited, in total, we recruited 6 GPs, 2 link workers, and 1 practice manager. We also recruited 4 strategic staff, and these were people, 3 of them had a strategic role in the initial setup of the attached alcohol nurse pilot. 1 of them wasn't involved in this, but they had a strategic role within alcohol treatment and recovery. We contacted 12 potential participants who were patients, and 7 responded and were recruited to our study. Next slide, thank you. So just moving on to the findings now, and just describing the PICANOS model to gain a better understanding of this service. So the aim of PICANOS is to engage patients with, say, serious alcohol or drinking problems who have not engaged with other alcohol services or who had low engagement with other services in the past, and then to link them to mainstream community services eventually. So the clients of PICANOS are quite varied. What they have in common is that they're all, say, non-engagers or low engagers with other alcohol services. There is a mixture of men and women, but they tend to be more men. In terms of ages, it's quite mixed, and employment status, it's also quite mixed. Because they are coming from or being recruited from deep end practices, most do come from levels or areas of higher deprivation, and many have alcohol use problems, but also may have drug problems as well. Many of them do have suffered from past trauma and have some form of mental health problem as well. So how it works is that when the patient goes to their GP practice, the GP then identifies if they are eligible for PICANOS, and then they refer the patient to the addiction nurses. The addiction nurses themselves could directly contact the patient, so that it's not up to the patient to contact the nurses, but the nurses contact the patients and then begin that initial step of setting up that support. The nurses, they visit the patients in their own homes, and then they conduct health assessments, and that's about not just their physical health, but also mental health as well. And then they provide a range of interventions depending on the individual patient's needs. So that could be things from medication to detoxification, to looking at their diet or sleeping habits, and also providing them with coping strategies. And the nurses then, towards the end, so it's an average of 12 weeks that the patients are with PICANOS. And towards the end, the nurses then directly link patients to a suitable community service for them to continue their treatment and support. So that's just an overview of the PICANOS model. Next slide, please.
Yeah, thanks, Andy. So one of our main findings from the study was that PICANOS was a person-centred approach for managing alcohol problems. With this discussed across many participants, including the addiction nurses, strategic staff, and patients themselves. The person-centred approach was discussed in relation to the fact that the addiction nurses reached out directly to patients. They visited them in their own environment at home, where the patient felt comfortable and at ease, and they were able to build that therapeutic relationship with the patient. So patients felt that they were honest, easy to talk to, they felt comfortable with the nurses. The PICANOS model also, the treatment and care provided by the PICANOS model was also tailored towards individual patients, as the addiction nurses took account of, the patient's individual needs and what they wanted from the service. The PICANOS model also provided more flexibility for patients than other alcohol services that are often set hours. So you can see from the middle quote that The addictions nurse does say that it provides that flexibility, as other addiction services tend to be 9 to 5. As part of the person-centred approach, participants also discussed that the addiction nurses provided support and motivation to patients during their treatment, as well as using their wide range of skills and knowledge to not only provide support to patients regarding their alcohol intake, but also their mental health and physical health and general well-being. Next slide. So one of the other main findings we found was that the Peak model facilitated collaborative working among practice staff. So for example, link workers who work with patients experiencing complex health and social issues were able to work with the addiction nurse when patients needed help with alcohol use and to introduce them to the service to address this. So from that first quote, you can see that the link worker discusses that they were able to work together where they had identified an issue with a patient around their alcohol use, and the service was introduced at this point. Given that the addiction nurse was situated within the practice, this enabled more detailed and quicker exchanges of information about the patient between the addiction nurses and GPs, for example, greater awareness of the service within the practice, and as a result, the nurses were able to build that relationship within the practice with the other staff. Yep, next slide.
Thanks, Danny. And so what, in addition to the person-centered care that the nurses provided, the care provided to patients was also coordinated. And the collaborative working that the nurses did with the GPs and practice staff, as well as the link workers, really facilitated this type of care. And so what it was that the ANs provided a care plan that was tailored to the patients. They kept the GPs updated with the patient's progress and were able to discuss anything that they needed to with the GPs, as well as the link workers. And then they also put the patients in touch with other services if needed. And so we can see from this quote here, one of the nurses is talking about a particular patient who had other physical health problems as well. And so they're saying that they were actually able to guide the patient through that sort of complex service we know that is the healthcare system, and so that the patient didn't have to be put on waiting lists and all of these things. And so, you know, they were handed over to a member of the community alcohol team, but all of the groundwork was done by us. So it was really that facilitating and guiding through that patient of any part of the system that was needed, but in a very coordinated manner. Next slide, please.
Okay, thanks, Andy. So participants in the study talked about some factors that had helped in either setting up or in running the Peak service. So firstly, support and buy-in from GPs and practice staff was important, particularly at the early stages, in terms of establishing good lines of communication and stimulating referrals to the alcohol nurse. So, for example, as mentioned by an alcohol nurse here, it's lovely when a GP practice is really motivated and enthusiastic about the service and they want to meet you and they're coming into us about it. So it's great when that happens. Staff and patients also talked of the benefits of having family support and helping patients engage with the service and to change their drinking behaviour. So, for example, as mentioned by one of the strategic staff, it's about building up that relationship as best you can. And they talk about the sort of family support in terms of helping patients sort of prevent relapse. So if you can equip families to assist in that relapse prevention work, then that benefits all. And one patient talked about the help he'd received from his family in terms of monitoring his drinking. I've got a wee chart, I've got a spreadsheet that my daughter done for me. I take what I have, 1 unit, 1 bottle of beer or whatever it may be. My wife marks it down, what my mood is, what food I've taken, etc. on a daily basis. Next slide, please. Okay, so there are also some challenges and barriers in terms of implementing and running the service. Then some of the alcohol nurses felt that there was limited support from some GP practices. and said that there was a little bit more work to do in terms of encouraging some GPs to embrace this new model of working. So for example, the service wasn't embraced by them at all, and I think because the GPs didn't embrace it, they didn't get the rest of the staff on board. That was one alcohol nurse talking. I think if they put the money in, even for a cluster of deep end GPs, to have one alcohol nurse or two alcohol nurses, it makes such a difference. I think just now we're still breaking down the barriers of GP attitudes, because GPs are used to doing the referral in the system, sending it off to the CAT, and that's the community addiction team, and then that's it. So there was also a lack of awareness of the service among some practice staff, including in cases where locum GPs were used in the practice. Some of the nurses experienced some practical difficulties in some of the practices where there was a lack of space for them. And there were also concerns amongst staff around funding of the service and whether it would continue. The next slide, please. Okay, so other challenges mentioned included some patient level factors. For example, the challenge of working with a stigmatized patient group who may be reluctant to talk about their drinking. There was also a reluctance among some patients to attend other alcohol services once they'd completed their Pycanos sessions. A wider challenge was thought to be a lack of awareness in general amongst patients in relation to the service. And finally, the alcohol nurses talked about trauma, which is common in the patients that they see, and that this requires enough time for them to build up relationships and trust with patients before going on to assess their mental health. And the quote there sort of relates to that last point, just about being able to sort of build up trust in sort of one of the patients, a young man who had experienced trauma. Okay, can I have the next slide, please? Okay, so participants were asked how the Pycanos service compares with other alcohol services. And in answering this, most comparisons are made with the Alcohol and Drugs Recovery Service, the ADRS for short. And compared with Pycanos, the ADRS services were viewed as less person-centred, with limited time and flexibility, and therefore being sort of less responsive and less able to help patients that were perhaps struggling to engage with services. And participants mentioned the stigma associated with attending ADRS services, especially where obviously there was sort of combined alcohol and drug services. They also felt that within the combined ADR services, a priority was given to drugs and issues sort of over alcohol, and that the ADRS had more focus on recovery as opposed to harm reduction focus taken in the Pycanos service. Communication between GPs and the ADRS was thought to be poorer by comparison. Wider alcohol services in the community were thought to be complex, and that this made it difficult for GPs to sometimes know where to refer a patient for help. And finally, an issue for all services to consider was how to help patients with co-occurring substance use and mental health problems. Okay, can I have the next slide, please? Okay, so these are just some quotes to illustrate these points. I'll just read one from a GP, and this relates to communication. One issue that we've got with the CAT team is that we don't necessarily get brilliant communication from them. Any patient contact I have, it goes in their notes about it. Any clinic attendance that patient has had in hospital, we should get a letter about. If we get letters about patients who are engaging with the CAT team, they tend to be few and far between, so they can potentially like months. So that's a GP talking about communication. Okay, so I'm just going to hand over to Danielle now.
Yes, so of course, like a lot of services, as we know, have been impacted by COVID, and there was a lot of discussion. There was discussion by participants that COVID had impacted the Pycanos service. There was mention by one GP specifically that COVID had impacted the fact that they weren't seeing patients as frequently face to face, and therefore alcohol problems may have been going unidentified. So they used a specific example about, you know, a patient may come in for a checkup or getting a skin lesion checked up on, and the GP may smell alcohol, and that might then bring up the issue around alcohol use, and then they may be able to be referred on to the service. There was also mentioned by other participants that referral rates have reduced, that there were delays in the service getting into practices, and that the addiction nurses were unable to attend practice meetings to update staff about the progress of PKNOS in the patients. Another impact of COVID was that the addiction nurses were unable to visit patients in their home for a period of time during the height of the pandemic. However, some adaptations were made, such as video calls and phone calls, just to keep in contact with the patients until they were able to go back in to see them. One participant, a patient, did note that they didn't reach out for help initially because they just assumed that everything was closed because of the pandemic. And there was also an increase in young people being referred to PKNOS post-COVID or following the initial stages of the pandemic, and people that were not necessarily non-engagers. Yeah, next slide.
So what we found overall that with PKNOS is a novel and unique service and a practical approach to supporting people with alcohol problems. Scouring through the scientific literature, there really is very little information about services like this. And so we really think that it is actually a very unique and novel service in this regard. And the three key elements that we've discussed really contribute to meeting the patient's needs, and that's the person-centered care, collaborative working, and the coordinated care. And both person-centered care and coordinated care are actually key principles of care that have been recommended by NICE in regards to caring for patients with alcohol problems. And so we can see that from our findings, PKNOS actually does this very, very well. In relation to the person-centered approach, it's particularly that care at home that provides that comfortable and safe environment for the patients, and that enables the nurses to build that trusting relationship with the patients. And that specialized treatment plan that the nurses also provide, that's tailored to the individual patients to meet not just their physical needs and focus just on the alcohol problem, but also on other identifying and trying to find the appropriate support for other problems that might be linked to the patient's alcohol problem. The collaborative working as well is a very unique aspect of the PKNOS. So being initially before COVID located within the practice, but since COVID, they've been working closely with the practices and practice staff. And so that's quite unique. And what that allows, that it brings together a range of different skills and expertise to support patients, many of whom have a range of diverse and complex needs. And the coordinated care, like I mentioned, it is one of those key principles of care. And the alcohol nurses, it's key to ensuring that all parties are informed of the patient's care plan and progress as well. Next slide, please. So these three elements really help to address some of the barriers that patients do experience when trying to seek support for their alcohol problems, particularly when we look at barriers from the GP point of view. So we know that most GPs, they are quite limited in terms of skill, time, but also those specialist skills or resources that are needed to really support people who have alcohol problems, who are non-engagers. In terms of challenges of identifying and engaging with patients as well, who really need this specialist support. One of the other barriers that PKNOS helps to break down is that of stigma. And so by the nurses actually going to the patient's home, it's just them and the patient, and maybe the patient's family might be around. So it really helps to reduce that feeling of stigmatization that patients experience by attending other community alcohol services. And the inability of community-based alcohol services it also breaks down that barrier of that inability to meet a diverse range, the needs of a diverse range of patients. So PKNOS does that very well. Although we've seen that there are some of the challenges and hurdles to overcome. And so what these things of the awareness and support of the service from GPs and practice staff, that really needs to be, more awareness needs to be generated so that everybody is aware of PKNOS and are able to then refer the correct patients to that service. And it's not just among the GP services, but also just around the general community about the existence of PKNOS and what's available. But also there are quite a lot of other alcohol services in the community as well. And so it's probably raising the profile of all of these services in a way that people can understand what is available to them, what is suited to them. The findings also raise questions about the alcohol and drug recovery service and how, how they can be supported to provide a more personalized service to patients, because we could see from some of our findings that some of the patients were very reluctant to go receive treatment from that from those other services because of that less personalized approach. And also one of the main challenges that still exists, I think, with all alcohol services is about supporting people who have co-occurring problems. So the substance use and mental health problems, and the decisions about which service, I guess, sees the individual first if they have these co-occurring problems. Next slide. So in conclusion, PKNOS is a unique and important service that fills a gap in treatment for people with alcohol problems that really are already seriously impacting on their health, who do not engage with other alcohol services. And the specialized and person-centered nature of the service, the participants reported that there was a positive impact on their drinking behavior, as well as the health and well-being. The practices also benefited from PKNOS as they were able to provide that specialized treatment. And so in that way, PKNOS was supporting the practices that couldn't offer this treatment on their own. We've seen that several barriers and challenges still exist in terms of patients accessing communities in general, and these really do need to be addressed. So for future research, we recommended that we definitely need more evidence around the effectiveness of services such as PKNOS for addressing alcohol problems in primary care. But more research is also needed on how to support people with, I suppose, substance use problems and or mental health problems as well. And we do recommend looking at considering long-term funding to ensure that services like PKNOS continues to run for a long time, to be able to serve these and support these, address these complex needs of patients in this particular, I suppose, patient group. Next slide. And that's it. So thank you very much. I'll just pass over now to Eleanor.
Thank you very much for sharing your research. Now I'll hand over to Linda Doonan, who is heads up the PKNOS team, which has been the subject of this research. Linda is the nurse team leader, so over to you, Linda.
Thanks, Eleanor. Yeah, sorry I don't have any slides prepared, but I'm just going to sort of talk through my experience of working with PKNOS. I was actually one of the alcohol attached nurses that was involved in the pilot, so I've been involved with this setup since 2015. So we secured 3 years funding back in 2019 from the Scottish Government, and that funding we were supported through Glasgow Alcohol and Drugs Partnership to roll out the PKNOS service. Within Glasgow City, it's based into 3 sectors, so it's northwest, northeast and south area. And what we did was we recruited 2 nurses to cover each of the sectors. So it was a senior band 6 nurse and a band 5 nurse. Although they're big sectors, as Andrea's already sort of said, that there is a criteria for our service. So initially, when PKNOS started back in 2019, one of the things was to look at the criteria for our service, because we can't take all alcohol referrals. So one of the things that Andrea had mentioned there, the main one was about trying to reach people who don't engage with normal alcohol and drug recovery services within the community. So that was one of the big ones, was to try and get the patients who have got a history of non-engagement. The other referral criteria for our service also is that we are trying to work with the people who we refer to as frequent attenders. So these are patients who access the acute services often because they're in alcohol withdrawal, because they're unwell because of their alcohol, or they're seeking detoxes. And we work closely with within Glasgow, we have addiction liaison nurses within our main hospitals in Glasgow. So we'll link in with them to try and pick up these people who are frequently attending acute services. And the other criteria for the PKNOS service is people who are attending GP who are physically unwell with possibly liver cirrhosis, who have got a diagnosis, liver cirrhosis, who might be open to the liver clinics in Glasgow, but they are continuing to drink. So that's the kind of three main criteria for the PKNOS service. And that's the thing that we've been trying to get through at the GPs, is that while we are GP attached, there is a criteria of patients that we will and won't accept. Over the first 6 months of the service, what we did was we developed our referral pathways, and we also developed our own assessment, which sits on our EMIS system within Glasgow. That assessment basically is used to pull information for reporting purposes back to the Alcohol and Drug Partnership. And that assessment is around roughly how much people are drinking in a week, their physical health, their mental health, do they have any children at home, are they supported? So the assessment is just not focused on their alcohol, it's focused on the whole individual. As Andrea had said earlier, it's very much person-centred. We look at their financial situation, their living situation, all things like that. We developed other things we developed was about audits. So obviously we had reports to put back to the ADP, the Alcohol and Drug Partnership, which both of our researchers in Glasgow help us with. So that gets done on a 3-monthly basis. So we input the information into our audits around, so 3 months before they come to our service, how often did they contact the GP, how many presentations did they have at A&E, and then we'll look at the same information 3 months after PKNOS involvement, and what we found with that is that there has been a decrease. So the first 6 months of their service was really about just trying to embed the PKNOS, what we're around, the referral pathways to us, looking at getting the two systems that we record on in Glasgow, which is EMIS and Care First, and how we get information onto that. And then what we did was we started in our first cluster. So we targeted our GPs by clusters because they're within clusters in Glasgow. So we started our first cluster in November 2019. Now this was pre-COVID. And at that time, it was really good because we were able to go along to the practice meetings. We met all of the GPs, we met the practice staff. So we met the treatment room nurses, the community link workers. And that was a really good way of introducing the service. We could then set out with them about our criteria of what the service is around, particularly the client group that we were trying to target. And that was good within our first clusters. It raised the profile of the service. We also at that time started to link in with other the community recovery services that are around Glasgow. So the We Are With You Ad Action services, SHAAP, Glasgow Council and Alcohol, because these are all services that we would refer patients on to once they had our input. So we raised the profile of PKNOS through doing a lot of networking at that time, that are pre-COVID. However, obviously, as you're aware that COVID started in March 2020, and for the initial 3 months after the pandemic struck, we were unable to go out and home visit. We did keep regular contact with patients through telephone. However, around about the May-June time, we were allowed to go back out home visiting, which we've been doing since May 2020. We've been going out using PPE. Even when other lockdowns occurred, PKNOS still went out and picked up referrals and home visited patients. So The difficulty then when COVID hit was that we were no longer able to get to the practice meetings to introduce the service to the GP clusters. So from probably March 2020, how we've rolled the service out is we've had to do that through MS Teams. We've contacted cluster leads. We've tried to get invited to the GP cluster meetings, and we've attended the cluster meetings, letting them know about the service, highlighting the service to the GPs. So we finally finished up, I think it was the tail end of last year. We were in all clusters, and at the moment that is around 142 GP practices now across the 3 sectors in Glasgow City that we've actually made contact with. Where we find the difference for PKNOS, certainly for the patients and what the patients' feedback is that we contact them quite quickly. So GPs will put a Sky Gateway referral through EMIS, and it's particularly now coming to PKNOS, whereas before it used to come to the local alcohol and drug recovery service with PKNOS on it, but we've managed to develop now that it comes straight to PKNOS and we pick it up through our EMIS system. So we try and contact that patient by telephone within 24 to 48 hours of getting that referral. Sometimes it's difficult to get people on the phone. So what we do is if we can't get the patient on the telephone to make that initial contact, what we will do then is we'll go out and door chat. We'll go out and do unannounced visits, chat the door, introduce ourselves and let them know that GP's referred them for alcohol support. The benefit of that is that they've seen or spoken to their GP. So by the time we make contact, they're motivated to actually do something about their drinking. So by doing the home visits as well, we've found by taking the service to people in their own homes, they tend to feel a bit more safer to talk about a lot of confidential stuff, about their background, about what's maybe, because some of these people have been drinking 30, 40, 50 years, it's been long-standing chronic problems. They also feel that, I think, with the PKNOS service, I will keep someone on my caseload for up to 12 weeks, so they're seeing the same practitioner for that 12 weeks. It's not different people they're seeing, and they're not having to recite their background and their stories. So at the very beginning, you're starting to build up that therapeutic relationship with your patient, and you're seeing them through that 12 weeks of their treatment. But as Andrea also said, we very much encourage family members to be involved. So when we do go to the home visits, with the patient's permission, if they want their partners or families to be involved in their treatment plan, then we very much encourage that for the families to come on board and be involved with the treatment plan. As I said, when we go out to do the initial assessment with patients, we don't just focus on their alcohol, we focus on their physical and mental well-being. You know, what is their mood like, what's their physical health like, what do they do during the day, what's their activities, did they work, are they working just now, do they have any children, who have they got around for support. So it's a holistic assessment. Now, some of our patients don't want to be abstinent. What they're looking for is maybe just a reduction in their alcohol. So we don't particularly push an abstinence-based model. We do very much start working from a harm reduction, and it's about just getting them to start cutting down their alcohol. Because it is all nursing staff that's in the PKNOS team, we're also able to do nursing interventions such as taking blood, so we're all venipuncture trained. So maybe somebody has not had bloods done from their GP for a few years, so we would take their bloods to have a look at their liver function tests, to look at other blood markers. We can give Papronex treatment, intramuscular Papronex treatment for 5 days, particularly if their diet's not good, they're quite underweight. So Linda,
yeah. I'm really sorry to interrupt you mid-flow there, but I'm just really conscious of time.
Okay.
Would you be able to wrap up? And I think some questions will probably come to you after this, if that's all right.
So, really, that's the kind of stuff that we do with the patients. Where we've found the benefit from the GPs is that it's the communication with the GPs. So we actually record our notes straight onto the practice system. So if we've seen a patient, we now have remote access to the GP practice notes. So we will go into the practice notes and we will write up what our contact has been with that patient. And the feedback we've had from GPs is that they now know that that patient's been picked up, that we've seen them and what we're doing with them. So we've kind of closed that gap a wee bit around the communication with primary care GPs. The significance of the study that Andrea and her partners have done, I think, has been extremely beneficial, because it does show there's other ways in which people can be engaged into alcohol care and treatment. I think there is very much still a stigma around about alcohol patients attending local community services because of the drug patients that attend. The big problem that we still have within Peakenos and Glasgow just now is still the lack of buy-in from our GPs, and we're trying to overcome that by obviously going back and revisiting. And because this is a primary care service, I'm hoping in the future that the funding for this service should come from primary care. And we're looking for this service obviously to be embedded within the primary care sector, so that we are able to sit within the practices and obviously deliver the service.
Brilliant. Thank you very much, Linda. Now I'll hand over to Dr Andrea Williamson, who is a deep end GP and health inclusion GP, as well as sitting on the deep end practice steering group. And if you want to just rattle through your presentation, if that's all right, and then we'll have time for hopefully about 10 minutes of questions.
Thank you. Yeah, no, I'm going to give a very brief response to the research. Yeah, I'm going to, oh, I'm moving, my slides are not moving. Hold on, I'm going to try and keep them. There we go. So I want to show this slide though, because this contextualizes what working in deep end practices does. This was old data, but sadly the data is not shifted from 2015 in terms of provision of resource versus unmet need to unmet need within deep end practices. So that's just to contextualize what deep end general practice is. So yeah, and so I want to talk a wee bit about, I'm going to really quickly go through sort of thinking about what the deep end response to this research most welcome is, and it's really just to highlight what I would tend to think on behalf of the deep end group are the key ingredients in terms of what this service has shown and what the research has highlighted. And I think I want to move beyond the idea that a key ingredient is that it's person-centred. It's actually about relational care. And I think Linda, illustrated really beautifully there, what that means. So it is about getting to know patients, and it's about stickability, and it's about maintaining that relational continuity over time. That's really important to patients in deep end practices. In this setting, it's about alcohol care and treatment, but actually that is a truism, we think, for most of the patients that we provide care to. And also it's been highlighted the real central importance of joined up collaborative care with the multidisciplinary team within general practice. That's also relational. That's also about professionals knowing each other and knowing when a GP or an alcohol nurse says, I'm really worried about that patient, I really need things to happen now, then actually people know each other and know that that's something to be taken really seriously. And the final really key ingredient of the sort of model that's been discussed today is this idea of no wrong door into specialist care. We've gained yet more. I mean, how many research reports do we need to hear about how complex services can be, how difficult and challenging it is for patients with problem substance use, including alcohol and mental health issues, to get the care that they need. But I think for me, a really strong and important message from this is that there should be no wrong door into specialist care. When a GP or a person asks for support for their alcohol use, that need should be met, and it's up to specialist services to work out what those best needs are, not the GP or the patient getting bounced around to, no, you're not eligible for me, you need to go somewhere else. But of course, as has already been highlighted, there are challenges. And I think, this idea of no wrong door is a challenge for specialist services. And also supporting people complexly, navigate that care system. But I actually think that's part of the role of what specialist services are, and that should be one of the important things going forward from this report too. There's all sorts of debates around, when proportionate universalism, like that this service was set up specifically to meet the needs of patients in deep end practices. Should that be mainstreamed? Should it be that all practices should have access to this sort of care? That's up for debate, but I would strongly be of support of the idea that this needs, first of all, expanded properly into deep end settings. There's also the challenge of the GP multidisciplinary team becoming quite crowded going forward. Where do specialist alcohol nurses fit into that landscape? I think this report is pretty good evidence that they should be part of that landscape. But also I think, really importantly is what this research and what the PCANOS model has to tell alcohol and drug recovery services more widely about what best practice should be for alcohol care and treatment. And I'm going to shut up there.
That's fantastic. Thank you very much, Andrea. That was really helpful. Well, I've been trying to keep an eye on the questions that have been coming in, and they are quite diverse. There have been 2 or 3 around sort of evaluation and that type of thing, but Neve Fitzgerald has actually responded to that in the chat if people want to take a look at that. But this research was very much qualitative and about the experiences of everybody involved in the service, patients and also all the healthcare professionals and others. There's some other things that have come up in the questions. One of them is about how PCANOS, I guess, links to other more sort of standard services in the world of alcohol and health. So both Wayne Galt and Alistair McGilchrist have asked about this. Like, how does PCANOS link to those other services? So how do you get someone into PCANOS from these other services or elsewhere? And then what happens to those people once they leave the PCANOS service? How do you ensure that they then enter those other services and get the support that they need? Is there anyone who'd like to answer that?
Yes, I'll answer that. So in order to get access to the PCANOS service, it's through the GP. Basically, it's through their GP practice. GP will send the referral to us, and as I've said previously, we have a strict criteria of if are they a frequent attender, do they have a history of non-engagement with alcohol services, and are they very physically unwell and continue to drink. So that's the criteria that we would look at. Where they go from us is that we very much try and continue that person's journey in respect to their recovery. So after the 12 weeks, so if someone's not maybe suitable to be detoxed at home but might need to go in for an inpatient detox, we refer them to our inpatient services, and we've done all that preparatory work. But then what we do is we transfer them back to the local alcohol and drug recovery service to continue the support. Or if a person has done well in respect to their treatment plan, we would then refer them on to some of our local recovery hubs in Glasgow, such as GCA, things like that. So although we keep patients for 12 weeks, sometimes longer, their journey doesn't just stop when they leave PCANOS. We very much try and put in a plan for when they leave PCANOS of where they're going in respect to their ongoing recovery.
Okay. Thank you. Have you got anything to add to that, Andrea Williamson?
No, it's just to say, I mean, of the patients who we interviewed, I think 2 were already discharged, who said one was very reluctant to sort of, access other services and very much was, I want to do this on my own. And one who had tried to access the alcohol drug service and said that, there was some challenges around the flexibility in terms of their schedule. And so I think that's something that also we could look at in the future of, so PCANOS is providing this, I think, this amazing service and preparing the patients to get to this point, but then it's what happens after in terms of how they engage with these other services, if they can maintain that engagement that they did with PCANOS as well.
Okay, thank you. Andrea, have you got anything to add?
Yeah, so it was just to say, so the other thing that PCANOS have done is that, if a patient is referred into the service but actually doesn't meet their service criteria, they then do ensure that they get linked in with the portion of alcohol and drug services that it is relevant for them to link in with. And that's a really, from a GP point of view, that's really important. So it's not coming back as a rejected referral and the GP then having to think, right, okay, where do I go next with this? That actually PCANOS sort that out, because they know the system really well and they can ensure that the patient gets linked in with the correct portion of care. We would love to see that happen across the specialist service sector.
There's been a couple of questions about MATS and medical assisted treatment standards, and I don't know if that's overly relevant to the PKNOS model as we're talking about now, but I do think generally it is a really good point that the MATS standards for drugs have certainly focused resource and potentially now starting to improve outcomes for people who use drugs. So this is something that we at SHAAP are exploring as to when the alcohol treatment guidelines are introduced in Scotland, hopefully at some point later this year, that they're backed up with those standards that therefore then focus resource in terms of getting support to people as soon as possible in the most person-centred way. But so to put that to one side, I think we've got time for one final question, which is around mental health services and how they sit alongside alcohol treatment services. I don't know if there's, obviously this is something that came up in the research where we found that people did sometimes have a history of bouncing between services. Is this something that any of the panel would like to reflect on?
Yeah, I mean, I can happily come into that. I mean, I think it's just one of the perennial issues. And I suppose, you know, one of the things that I think the PKNOS model has tried to do is that, you know, it actually, I'm going back to relational care again, relational continuity, is that that's actually a really important element of care for people, because it enables people to at least begin the journey of acknowledging the sort of co-occurring issues that they might have, although are they really co-occurring? Because, you know, as the evidence says really, really strongly now, most people use substances to escape and cope with difficulties in their past, and most people are using substances because they've got symptoms that they need to deal with. So it's actually not really a comorbidity. It's professionals that tend to see it as a comorbidity, not really as not really people that experience it. So you know, that's the multi-billion-dollar question at the moment, how we better integrate services. But I think I suppose for me it's about always going back to being about the patient or the person is at the centre of the model of care that's provided, not professional silos and specialisms.
Okay, thank you. Well, before we wrap up, has anyone on the panel got any final reflections that we feel they really must get out there before we finish?
I would just like to say, I mean, thanks to everybody who attended today, and just looking through some of the points I've made on the chat is really interesting, so I'm noting them down. But I just wanted to say, you know, I think it's this research has really raised a lot of discussion and I think key questions for how, you know, we help to support people who have alcohol problems in Scotland. So my hope is that we just continue to press on with this research and find and try to improve things for Scotland, you know, sooner rather than later. So thank you very much.
Thank you. And I'd just like to say a thank you from SHAAP to both Andrea and your team for carrying out this research and for all the work that's done in the PKNOS project, because clearly it makes a huge difference. And this is definitely the sort of thing we really want to learn from and see make a difference for everybody who has an alcohol problem, who live in some of our more socio-economic deprived communities. So I think it's really important that we share this as much as possible, and we will be working with the team over coming months to get this out to as wide an audience as possible and try to actually change things for the better. So thank you so much for all your work, and thank you to everybody for attending today and for asking such brilliant questions, and apologies for the ones we didn't get to. I guess that just shows just how important this is and how we could discuss it forever, but actually what we need to do is get on and change things. So thank you so much. And we'll be sending out an email after this with the recording. So thank you and goodbye.
Thank you.